this is a little bit of a big topic for 25 minutes. So I'm trying to stay on time for you guys. So the notes will be helpful.
All right.
Now, how are things in Italy?
Everything's fine by now. Fortunately, doing well. So if you don't mind, even if we are on a little bit, earlier, we can start the meeting. Up to you.
Yeah, ready whenever you are.
See? All right. Yeah, I think that is fine. We can start it right now, if you don't.
Sure.
Right?
No problem at all.
Okay. So, all right. Ladies and gentlemen, welcome back to our International Ground Round, Equality. Today's talk is going to be focused on CSF. I'm very proud and very happy to have a guest speaker from Cleveland Clinic. Good morning, Chris. Hope you're doing good.
Doing well, thank you.
So Christopher Roxbury is working as a consultant at the Cleveland Clinic in the US. Today's talk is going to be focused mainly on the CSF, but on management, on a comprehensive management of those patients that are having a spontaneous CSF leakage. So we will go throughout not only the diagnosis, the medical treatment, the surgical treatment, and sometimes also how to avoid post-op complication, I guess. For all the attendees, I remind you that for question and answer, we will go throughout the question and answer at the end of Christopher talk. So please, Chris, if you would like to share your screen. Thank you.
You guys see my slide?
Yes.
All right. Well, hello, everyone. Thank you to Dr. Dehgani and the Naso Sano Association for the invitation to speak today. Really excited to present our experience in managing our patients with cerebrospinal fluid leaks from the initial diagnosis to long-term follow-up. My only relevant disclosure is that I co-edited a textbook with my partner, Dr. Raj Sinwani, and I receive royalties from Elsevier for this book. So I have a somewhat ambitious agenda for this talk, which will range from reviewing the epidemiology, pathogenesis, and classification of CSF leaks, discussing the reconstructive algorithm for anterior cranial base repair, discussing morbidities associated with these surgeries, and also briefly delving into adjunct management of idiopathic intracranial hypertension. Each one of these objectives could easily be a talk of its own, but I hope to paint a broad picture of how we can think about and improve the quality of care we deliver to these patients. Let's first start by discussing a classification schema for CSF rhinorrhea. Broadly speaking, CSF rhinorrhea can be broken into traumatic and non-traumatic causes. Traumatic leaks include accidental trauma, such as blunt or penetrating injuries, or iatrogenic leaks in the setting of surgery. Non-traumatic leaks, which will be much of the focus of this talk, can be broadly categorized into high-pressure leaks and low-pressure leaks. Surgical CSF leaks can further be subclassified as either unplanned leaks, where the surgeon did not expect to encounter a leak, or planned leaks, where the surgeons knew going into the surgery that a leak would occur. Unplanned leaks can be noted immediately intraoperatively or can be discovered in delayed fashion, either because no intraoperative leak was appreciated or because a primary repair of the leak failed. Our goal as rhinologists and skull-based surgeons should always be to avoid unplanned leaks. We'll briefly next discuss non-traumatic leaks, which have a more varied underlying pathogenesis. This is a schema to classify non-traumatic leaks. As mentioned previously, these can be due to elevated intracranial pressure, as we see in patients with IIH, hydrocephalus, or intracranial tumors. It can also be associated with normal intracranial pressures due to a host of other disease processes. These can be broken down into erosive processes such as neoplasms, inflammatory conditions, and infections that lead to violation of the skull base or congenital malformations. It's always important to have a high suspicion for idiopathic intracranial hypertension in any patient presenting with a non-traumatic or spontaneous CSF leak. As we all know, IIH is a syndrome of elevated ICP without a detectable cause in the absence of hydrocephalus. Its most common symptoms include headache and visual changes, with blindness occurring in up to 25% of untreated cases. This is an epidemic in the US, affecting a growing number of overwhelmingly young, obese women. When suspecting IIH, imaging studies can be very informative. Findings such as empty cella, posterior globe flattening, optic nerve sheath tortuosity, expanded Meckel's cave, and transverse sinus stenosis have all been associated with higher rates of IIH. And a large systematic review noted that transverse sinus stenosis had the highest pooled sensitivity and specificity for predicting the disease. Unfortunately, transverse sinus stenosis is often difficult to appreciate on standard MRI, and so MRV should always be considered in patients where there's a suspicion of IIH. With this brief overview in mind, I'd like to present two patients that I saw in my clinic during my time in practice in the University of Chicago that highlight the similarities and differences in presentations of this disease process that we see. Case 1 was a 44-year-old female with a 1-year history of right-sided clear rhinorrhea that occurred spontaneously and was positional. She did note in her past medical history a history of chronic headaches, but had no history of head trauma. She endorsed a history of septoplasty for nasal obstruction about 5 years ago, which was not associated with the onset of her current symptoms. Her BMI was noted to be 25. Case 2 presented with a 6-month history of left-sided clear rhinorrhea that began in the setting of trying to forcefully blow her nose during a sinus infection. She also endorsed positional drainage. She did not endorse headaches, but did note long-standing pulsatile tinnitus. She has no known history of head trauma, nor has she had any surgery on her nose or sinuses. Of note, her BMI was 42. Both case 1 and case 2 were noted to have unilateral clear drainage upon bending over in clinic. Nasal endoscopy was performed in both cases. This was unremarkable in patient 1, while in patient 2, there was mass effect and pulsation noted in the left olfactory cleft region. Both patients had samples of their clear nasal drainage collected in the clinic, and both were noted to be positive for beta-2 transferrin. This is a glycoprotein found in CSF, perilymph, and aqueous and vitreous humor, and it remains the preferred test for clear nasal drainage in the US. Studies have shown sensitivity upwards of 87% and specificity upwards of 71%. Typically, about a half milliliter is required, so if a patient is having a very low flow or an intermittent leak, they may need to be instructed on how to collect a sample at home. Samples can be collected over several days if needed, and they do not need to be stored on ice. One of the biggest downsides to this test is that it can be processed only at select laboratories, and of course, as a result, the results may take days to weeks to return. As a result, some have advocated for the use of beta-trace protein, which has a much more rapid processing time. However, beta-trace protein also has its drawbacks, mainly being that it's ubiquitously present in bodily fluids, and therefore the interpretation of the test relies on the concentration of the sample. This can make beta-trace protein a bit more difficult to interpret, and it's also not widely available to us in the US. So back to our cases. Thin-cut CT imaging was performed in case 1 and this patient was noted to have a small midline clival defect in communication with a right dominant sphenoid sinus. MRI was also performed, and on this T2 sagittal image, we can see a T2 signal consistent with small meningocele in the area of the clival defect. In contrast, our CT imaging in case 2 shows a large defect in the left posterior fovea ethmoidalis, which was consistent with an encephalocele on MR imaging. These two cases highlight the importance of the preoperative workup in order to confirm the leak and localize the site of the defect. While nasal endoscopy can be helpful, we rarely see an obvious encephalocele, such as the one we see in this endoscopy of a different patient of mine. In one of the largest studies to date, the sphenoid and ethmoid sinuses were overwhelmingly more likely to be the sites of leak when compared to the frontal sinus. Typically, standard CT and MR imaging can localize the defect, as can be seen here in a different patient with bilateral lateral recess meningoceles. However, in some cases, advanced imaging such as CT cysternography should be performed, where administration of intrathecal contrast and serial imaging can determine the location of very small defects, such as this right planum sphenoidale defect on the upper left frame and this left cribriform defect on the lower left frame. And of course, we should keep in mind why all of this matters. Generally, patients are quite bothered symptomatically by their nasal drainage, but the risk of intracranial complications is what we are really trying to mitigate. A large prior multi-institutional cohort study showed that longer time to presentation was associated with higher risk of complication. And so, of course, delay in repair can potentially put these patients at risk. These authors also showed an inverse correlation between BMI and risk of intracranial complication, presumably due to high flow leak and lower risk of ascending infection. They also noted higher rates of meningitis and seizure in patients with lateral recess defects. Now that we've diagnosed and localized our defects, we're ready to proceed with surgical repair. Just as in any other reconstructive scenario, it helps to have a reconstructive ladder in mind when repairing an anterior cranial-based defect. The base of the ladder includes free grafts, which can be either autografts, such as mucosa, fat, or fascia, or synthetic grafts. From there, local pedicled flaps can be considered and are generally the workhorse in reconstruction of high flow or high pressure defects. When local pedicle flaps are not available, regional pedicle flaps, such as the pericranial or TPFF, can be considered. And when all else fails, free tissue transfer can be used as a rescue technique. Discussion of regional pedicle flaps and free tissue transfer is a bit beyond the scope of this talk. Free grafts are perhaps the most commonly utilized. Autografts can be mucosa from the septum, middle turbinate, inferior turbinate, or nasal floor. Less commonly, we use fat grafts from the abdomen or thigh, particularly when there's a large amount of dead space to close. In our practice, we're more frequently using fascia lata as an underlay in either a unilateral or a unilayer or bilayer fashion, especially in our patients with large defects or suspicion for IIH. There are a variety of synthetic grafts available with varying handling properties, the choice of which to use typically comes down to surgeon preference and institutional availability. Free grafts have been proven effective in many prior case series, meta-analyses, and systematic reviews. The studies highlighted here, which were performed in the early 2000s and 2010s, show leak rates in the 8 to 10% range, which are likely higher than the rates we're currently seeing due to improvements in surgical technique, instrumentation, and materials. A retrospective study evaluating free graft techniques at our Johns Hopkins cohort showed a leak rate of 7% with a favorable rate of 4% in low flow leaks and a rate of 50% in high flow leaks. This data suggests that multi-layer free graft reconstructions are sufficient, but only in the case of a low flow CSF leak. If the leak involves a cistern or ventricle, if the defect is greater than 1 centimeter in size, or if there's concern for IIH, regional pedicle flap should be considered. This is an example of a harvest of a free mucosal graft from the right nasal floor. This is a very easily harvested graft using a monopolar's needle tip bovie. Once we outline the graft, which we can actually extend onto the lateral nasal wall or on the septum if we need a larger graft, we can then elevate this off the mucoperiosteum of the nasal floor. And then we can use this as needed. Our free graft sites in this area usually mucosalize quite well. This is a case of just a very small cellar defect after a transsphenoidal approach. And we use this as an overlay. Once we have this flap in place or this graft in place, we can seat it in place with some absorbable material, Fibrillar, and some glue. Here's an example of a harvest of a right inferior turbinate free mucosal graft. We clamp the inferior turbinate and then incise it sharply with turbinate scissors. And once we get to the back of the turbinate, we're going to truncate it at the stump. We'll then cauterize the turbinate remnant, and off the field, we can elevate the mucosa off the underlying conchal bone. This was another example of just a defect from a cellar approach. We placed a Medpor plate to help with preventing prolapse of the diaphragma, and then we're placing the inferior turbinate graft here. Again, once the graft's in place, we typically will use Surgicel Fibrillar to sort of seat it, make sure it's opposing the bone well, followed by just some dural sealant for helping with burst pressures. This is a case of a lady who presented with a right lateral sphenoid recess encephalocele, which we exposed via a modified transpterygoid approach. You can see even with the 30-degree endoscope, we're having trouble really visualizing the entirety of the encephalocele. So we can drill down the sphenoidal process and get better access to the lateral recess, which we're doing here. Once we have better access to the encephalocele, we can reduce it. We're going to do that in this case with a coblator, but you can use bipolars to do this as well. And really, ends up being quite a small bony defect. And so this is one that's really amenable to placement of a previously harvested inferior turbinate-free mucosal graft. In every case where we expect a high flow leak or a large defect, we prep for fascia lata. An incision is typically designed in line with the greater trochanter of the femur and the lateral patella. The incision is typically 3 to 5 centimeters in length and on the upper 1/3 of the thigh, as the fascia is broader here and we can hide the potential scar under shorts. Dissection is carried through the subcutaneous fat, at which point the fat can be harvested for a free graft as well. The fascia lata is encountered just deep to that subcutaneous fat, and we typically incise it sharply and dissect it off the underlying muscle while taking care to avoid violating the muscle layer beneath. The incision is then closed in layers and typically heals up quite well. So the workhorse of reconstruction are local pedicle flaps, which I'll briefly describe here. There are septal flaps, most famously the nasoseptal flap pedicled off the posterior septal branch of the sphenopalatine artery, as described originally by Haddad. Another septal flap that's been described in Italy and in fact published by Dr. Dehgani and his colleagues is the septal flip flap pedicled off the anterior and posterior ethmoid arteries. Several flaps from the lateral nasal wall have also been described, typically utilized when we do not have septal flaps available. These include the middle turbinate flap, which is less robust, technically difficult, and has a shorter arc of rotation, and the inferior turbinate flap, which has a more robust mucosa and a better arc of rotation, especially for lower clival and transodontoid defects. So let's see how we went about case one. So after we widely drill out the bilateral sphenoids, we can see a very small meningocele in the clival recess, right where we expected to see it based on the preoperative imaging. We remove all of the intrasphenoidal mucosa and drill away all of the intrasphenoid sinus septations to provide an adequate bed for our reconstruction. You can see this patient had quite a few intersinus septations, and we just meticulously drill these down flush with the back of the clival recess to get good access and good exposure for our repair. Due to the very small size of the defect, it was difficult to place an underlay. However, knowing that this was in communication with the prepontine cistern, we did place a bilayer underlay of gel foam, and we ended up tamping this down as best we could. Once the gel foam was in good position here, we're going to cover this with a nasoseptal flap. And again, we don't typically use any non-absorbable packing in these cases. We'll go ahead and make sure this flap is opposing all the bony edges, and then we're going to seat it in place with Surgicel fibrillar balls. And then we're going to use a dural sealant at the end, again, to help with burst pressure. So here's her postoperative contrast-enhanced MRI, which shows good vascularity of the flap. Let's take a look at case two. In this case, we had to perform a left-sided complete endoscopic sinus surgery and septoplasty in order to expose the encephalocele. Once the encephalocele is fully exposed, we used a 3-handed technique to reduce the encephalocele with bipolars. These ethmoid defects can be challenging due to their geometry and need to be fully cleared of all ethmoid partitions while also ensuring patency of the sphenoid and frontal sinuses. The area of the defect also requires a lot of extra dissection and careful demucosalization to provide a bed on which the reconstruction can lay. So we're going ahead and getting some hemostasis here with some fibrillar. We're going to use some bipolar to help to fulgurate and demucosalize the edges. And in this case, since we had already performed a septoplasty for access, and given that her opening pressure was elevated, we elected to perform a modified nasoseptal flap for repair. So we're just making sharp incisions superiorly along the septal mucosa here. And then we're going to do the same inferiorly. And we're just going to rotate this anterior aspect of the nasal septal mucosa up to cover our defect. Once the flap was elevated, we placed an inlay of Duramatrix. And you can see we're just seeing this as a bony underlay. And then we're going to cover that with our flap. And just, again, make sure that it's opposed fully to the overlying bone using some fibrillar balls and, again, some dural sealant. This is her post-operative endoscopy at 2 months. She has good patency of the sinuses and excellent healing of the nasoseptal flap. She still has some continued post-operative edema, but is asymptomatic from this. Here is case 2's post-operative imaging, again showing good vascularity of the modified nasoseptal flap. Just a word on CSF diversion. I'm sure many of you saw the fluorescein we utilized in both of these cases. In our practice, for our spontaneous leak patients, we place a lumbar drain at the beginning of the surgery to obtain an opening pressure and instill fluorescein to help localize and rule out multiple defects, which can occur in some patients with IIH. There's conflicting evidence regarding the utility of drains and prevention of postoperative leaks, and more studies should be performed in this area. So now that we've repaired both of our patients' defects, let's briefly discuss important considerations in postoperative care. The most common adverse sequela of skull-base surgery is crusting, which is present in essentially all patients in the early postoperative period. With attention to gentle debridement and nasal hygiene, most patients will resolve their crusting in less than 3 months. But in some patients, and particularly those who've had a nasoseptal flap or those who've undergone radiation therapy, the crusting can persist long-term. Generally, the relationship with patients following skull race repair requires long-term follow-up and debridements as needed. But most patients do not require extensive debridements, and many do not describe bothersome discharge, cachosmia, or nasal obstruction, even if they continue to have mild crusting at the nasoseptal donor site. Studies have looked at ways to mitigate crusting, with autologous materials being significantly associated with improved quality of life and decreased crusting. Sinonasal outcomes always come secondarily to preventing postoperative CSF leaks, which can lead to high morbidity and significant costs when readmission is required. As a result, skull-base surgeons impose a variety of restrictions on patients with regard to postoperative activity, flying, driving, and CPAP use. A recent expert practice statement from the American Rhinologic Society looked at these precautions, and the experts reached consensus that precautions should be utilized, but widely varied in terms of how long to require them. Avoiding non-absorbable packing remains one way to improve postoperative sinonasal quality of life, with likely no ill effects on repair success rates. In my practice, we initiate saline mist post-op day 1 and then transition to saline irrigations at week 2. In rare cases of prolonged crusting, I'll use mupirocin rinses, and that's been helpful in select cases. Of course, there's no substitute for meticulous follow-up and debridements as necessary. A study from Henry Ford showed only 2 failures in a series of 73 patients in which only absorbable packing and sealants were utilized. Our unpublished series from nearly 100 patients at University of Chicago had only 1 failure. However, there are still many surgeons who prefer non-absorbable packing, as evidenced by the aforementioned expert practice statement, where the authors could only reach consensus on the fact that packing is safe and that the surgeon can decide on their own which packing to use. All of this is to say that there's not really any postoperative standard of care for these patients. In fact, a number of years ago, we surveyed the North American Skull-Base Society and noted that in regard to essentially all postoperative practices, there's significant variation in practice patterns among surgeons. While precautions tend to be followed for longer periods of time in those patients with high flow CSF leaks, there is still no consensus on the amount of time patients should be on bed rest, how long they should be off work, how long they must avoid driving or flying, and how long they must avoid CPAP. All of these factors play a significant role in postoperative quality of life, and as of now, there's little evidence to guide these practices. In the last few minutes, I'll discuss postoperative treatment of IIH using our case vignettes for guidance. Our first patient had a preoperative and clamp opening pressure within normal limits. She did well in the initial postoperative period, and at post-op week 3, did not have any evidence of CSF leak. Her headaches improved, but to ensure no underlying ICP elevation, we did refer her to outpatient ophthalmology to rule out papilledema. She did well and had no leak at 3.5 years post-op, and her leak likely occurred in the setting of a congenital midline defect without underlying IIH. The postoperative course for our second patient was a bit different. She had significantly elevated ICPs and so was initiated on Diamox 500 BID. We elected to proceed with serial LP, and her post-op week 3 opening pressure was still 38, so we increased her Diamox and did eventually note a decrease in her opening pressure to 24 at post-op week 6. She never had any evidence of post-operative leak, but given her difficulty with losing weight, a bariatric surgery consult was placed. So as we can see in these two cases, case 1 had no evidence of IIH, whereas case 2 did. While both patients did well at most recent follow-up, we know from the literature that success of managing the elevated ICP is critical for the success of the repair. However, there's no consensus on the best way to manage the ICP. Some management strategies are listed here, many of which we discussed in our description of case 2. Of course, permanent CSF diversion is an option for refractory IIH patients or those with recurrent leaks, although the morbidity of these procedures is high and we tend to reserve them only for the most difficult cases. It's also very challenging to get patients to agree to shunts as well. So I hope that framing CSF rhinorrhea with these two similar yet pathophysiologically different cases helps to illuminate several important concepts. Any patient with unilateral watery rhinorrhea should be considered a CSF leak until otherwise ruled out, even when the patient does not have a classic picture of IIH. While our testing is currently adequate in most cases, we need to improve our detection of leaks, particularly with point-of-care testing. Reconstruction depends on the location, size, flow of the leak, and suspicion for IIH. Further studies are needed to identify ways to balance the risk of postoperative leak with problematic postoperative sequelae such as crusting. And management of ICP is crucial to successful long-term outcomes, and further studies are needed to improve and standardize our care in this regard. I'm lucky to work with this world-class anterior cranial-based team at Cleveland Clinic, shown here, and thank my colleagues for teaching me much of what I know and apply to the care of my patients on a day-to-day basis. Thank you guys very much for listening. I'd love to collaborate in some of the areas for further research highlighted in this talk. And so please feel free to email me at either my work or personal email address listed here. Looking forward to hearing from you.
Thank you, Christopher, for your brilliant presentation. As we said from the beginning, the whole argument was to set up the management from the diagnosis to the medical treatment and the surgical treatment. So if you don't mind, I would like to go ahead with the questions. If we can stop sharing your screen, I have the possibility to go ahead for the question. So the first question is coming from France. Why are you removing mucosa in order to place the graft?
Yeah, it's a great question. So there's a couple of reasons. The first one is that you really have to have a good kind of circumferential area of exposed bone in order to place your graft so that the graft will actually adhere to the area where you're trying to repair. If there's mucosa under there that's secreting mucus, that can lead to the graft not taking as well. The other reason is that if you have trapped mucosa under your repair, long term, you could be at risk for things like mucocele formation.
Yes, that's something which is struggling then for the second treatment, and of course, having a bone completely exposed will cover that defect directly with the mucosa. The second question is fascinating because I never used that. I think that the use of coblation is something that we are missing, but it's getting quite more useful and in recently and lately for me. So this colleague is asking from Egypt, do you have any recommendations for the coblation setup in order to use it for the encephalocele reduction?
Yeah, so we have a coblator that we like. There's a specific handpiece. It's called the ProCise Max wand, which works really well for endonasal applications. And then there's like an ablate function and a cauterize function. We usually set the ablate function on 5 for an encephalocele, and we put the cautery at 3. We've just anecdotally, when we went up higher on the ablate function, we've had some patients have some like postoperative edema from that. So we kind of lowered the ablate down to 5. And the downside with that is that it takes a little bit more dissection. If you have a higher ablate, you can kind of get the tissue reduced sooner. We like the blade on like 7 for tumors, and it helps you really kind of control the bleeding and reduce the tumor. But when you're dealing with an encephalocele, you have to worry about transmission of that energy across the skull base, and so we tend to go at a little bit lower level of energy for those.
Okay, so let me ask you this personally for myself. I'm taking the advantage of this also. So we use it ablation for, of course, tissue reductions such as adenoids and tonsils. When we have that one, we have that no commercial conflict of interest, but we do use a coblation system, the coblator, and they having a setup which is already automatically both for the turbinate reduction and for coblation for the tonsils. So you mean that in order to avoid any energy release for the brain, we should set it up in a lower energy, how to say, transmission, right?
Yeah, that's been our practice. Our device, we have like a console that you can actually like choose the level of joules that you're gonna use. So we just again anecdotally, there's not great evidence to support it, but we've had some patients that had a little bit of edema post-op. They didn't have any problems, any neurological deficits or anything. But when we saw that edema, we said, well, maybe we should be a little bit more careful about the use of the coblator in those cases. So that's sort of how we end up, just going with a little bit lower level on that.
Okay, because for the audience, we usually use bipolar before placing the graft to retract the encephalocele. And once it's retracted inside, then we can place that one.
Yeah.
Thank you for
Yeah,
that.
we use bipolars, very frequently as well. It ends up being kind of a conversation with your neurosurgery partner as well. Some are more favoring the bipolar versus the coblator. So it's just kind of a bit of discussion with your colleague and using whatever works best. But we use bipolars very frequently, and they work very well, as you can see in that second
Yeah,
case.
it was brilliant. In fact, I was thinking about it. Another question is coming from Greece. In case of recurrent or refractory CSF leaks, so what advanced treatment strategies do you pursue?
Yeah, so it depends a little bit on the sort of underlying etiology, right? So, if it's a patient who has IIH and they have a recurrent leak just because their pressure is, completely, elevated and not well managed, that's a patient where, we'll oftentimes discuss, doing a repeat repair and doing a shunt during that same hospital stay. If it's from poor wound healing, for instance, like say you do a repair and your nasoseptal flap has necrosis, or if it's a patient who's had prior radiation and they're not healing well. We've had some success with calling in our facial plastic surgery colleagues and doing sort of small radial forearm free flap and anterolateral thigh free flaps for those patients, but those are pretty rare.
Other question from India. What percentage of your patients experience recurrent leaks, and what factors are the most predictive of recurrence?
Yeah, it's a great question. Luckily, in our sort of series, we've had very few leaks. I had one patient when I was in Chicago that leaked actually kind of in delayed fashion. He had a big suprasellar defect, and he was like 9 or 10 weeks post-op, and he had this like sneezing fit and started leaking at that point. And basically, when we took him back to the OR, we realized that his nasoseptal flap had just kind of like fallen forward. So that was an easy fix. We actually just tucked some fascia lata in there to reinforce and then put the flap back up. But I would say in terms of in general, the patients that are most likely to fail and they fail long-term are those with IIH where it's not recognized. So that's why, we're in the habit of really checking the pressure on our patients. We always do that opening pressure. And then, the more important one probably is that clamp pressure that we'll typically do around 48 hours post-repair, as that should sort of give you a better sense of like, what is the actual pressure, right? Because if they're actively leaking when you do that opening pressure pre-op, that might be artificially low. And so when we do our clamp pressure, that gives us a better sense, is this someone who we're really worried about? And we're not, we don't have any hesitation to starting them on pharmacotherapy. Usually we use Diamox, but people talk about using topiramate and Topamax. So, really making sure that you have a good plan for managing the pressure is sort of the most important, especially in these spontaneous leak patients, because, as we're learning, it's more likely the etiology in the majority of them.
We have just time for other two questions. The first one is from Malaysia. Are there any emerging technologies or techniques in the diagnosis or management of spontaneous CSF that you believe will become standard practice in the near future? That's a good one.
Yeah, it's a great one. It's a tough question. I think, we need to put our heads together as a field and really try to advance things. I think, in my mind, the biggest thing that I think probably will advance in the near term is the diagnostic process. I know there are some folks working on point of care testing. There's been some studies of people looking at, like topical fluorescein in the nasal cavity in the clinic, which hasn't really been very promising. But I think, with nanotechnology and some of what's available and getting to be more available nowadays, I think we can come up with an assay where perhaps, we, can place a pledget on, in someone's nose in the clinic and have it diagnose the leak immediately without having to send off a lab test. Now, that being said, a lot of our diagnosis is clinical. We see that they're leaking from one side, they're an obese patient, it's usually, we have a pretty high index of suspicion. And there's actually a study out of Henry Ford that came out maybe back in the summer that kind of showed that there actually are, a fair number of false negatives, even with beta-2 transferrin. So, even if the test is negative, you have high suspicion clinically. If there's a defect on your imaging, you're not going to necessarily say, oh, this must not be a leak. But yeah, I don't know if I answered the question.
Yeah. No, you did.
That's sort of what I see.
I think that probably it's a recommendation for future studies. What you said is actually we are searching. The urge is to have evidence of something that we can put inside our nose and avoid all these, fluorescein and this invasive somehow procedures instead of
Absolutely.
And I do completely agree with that. I remember few years ago that a paper was discussing the percentage of CSF leakage in patients undergoing frontal sinus surgery. And there's evidence of like 75% of patients that having CSF leakage, which is not visible and will retract by itself. So some cases, even if we do surgery, sometimes we can, proceed and we produce a CSF leak. Some of those are resolved spontaneously. In the other occasion, in this particular example, for example, for the spontaneous one, what do we need is something that is, easy to use, fast, and go, to the OR. Last question is coming from Turkey. Can you share a particularly challenging case of a spontaneous CSF leak you've managed, and what insights it provided into the comprehensive management of this condition?
Yeah, so we had a patient that had a lateral recess defect, actually had bilateral lateral recess defects, and was only leaking from one of them. But we elected during the surgery to repair both meningoceles. Her ICPs were like in the 40s, and her BMI was 55. So we initially we repaired it with nasoseptal flap on the leaking side and a mucosal graft on the non-leaking side. So sort of early on in my practice, and unfortunately the non-leaking side kind of sprung a leak from where we did a free graft. So eventually we took her back, and we had we always preserve the contralateral pedicle when we're doing nasoseptal flap, and so we were able to get a nasoseptal flap on that one. And eventually, she did pretty well. This was, several months, after the index procedure. But she was one where we, during that second surgery, said, hey, you probably do need a shunt, just because her BMI was so elevated, her pressures were so high. There's also a lot of challenging cases with, malignancies and sort of posterior fossa defects. Those are sort of a little bit of a different story, because those are, they're not the spontaneous leak patients. We're not really dealing as much with high pressures in those patients. We're oftentimes dealing with, the fact that they've already been radiated or they've already had surgery and there's no flaps available. You're then relying on pericranium or TPFF, which we really try to avoid because it's sort of really painful to do. And in those cases, we've had, like I said, a few patients where we kind of call on our free flap surgeons to help us out. So yeah, a lot of different variables that can play a role and can make some of these cases very challenging. Thankfully, the majority of them do pretty well with these, kind of standard endonasal techniques, as long as you're, being meticulous with your dissection and, making sure you have a watertight seal.
Yeah, I think that the bilateral encephalocele on a lateral recess is something that is quite difficult to manage, especially because you are using both sides simultaneously, and then you're actually using your whole armamentarium for this one. And the next step will be challenging pretty much.
Yeah. Yeah,
So,
those are long cases. They're tiring.
oof, don't tell me. Thank you, Christopher, for being with us. Thank you for all attendees. I remind you that this, such as the other live ground runs, are available on our social media platform. You can watch it again anytime you want. And just a quick reminder for the upcoming meeting, November 6th, with our colleague Saad Al-Saleh from Saudi Arabia, which is talking about the establishment of a multidisciplinary skull-based surgery program, strategies for success. So thank you, Christopher, again. And if you have any questions, watch it again and send an email directly to Christopher Roxbury for your inquiries. Thank you.
Yeah.